Good morning. Thank you so much for having me. I'm delighted to be here to talk with you today about using big data to examine intergenerational transmission of economic disparities. I don't get a chance to talk about that often enough. Implications for health outcomes. So I'm so happy that this group decided to focus on this topic. All of the studies that I will be presenting today use big data, and the outcome I'll be looking at is not preventive services, but preventable mortality. And I am honored to talk with you today, so thank you very much. So just to give you a sense of how I've organized my talk, I'm going to talk about fusing structured and unstructured big data for health disparities research, then the concept and moving towards economic determinants and the social determinants of health, then wealth, which is the mechanism for intergenerational transmission of economic disparities, and finally show you a few tools that NIMHD has developed, which I think will help you. So NIMHD, the National Institute on Minority Health and Health Disparities, is invested in big data. We need big data. We need it to improve clinical care, population health. We need it to reduce health disparities and to reduce intergenerational transmission of health disparities. So there are two types of big data platforms. Probably the one you think of most often when you hear of big data are the unstructured. But let's ground ourselves in something that's more familiar, and that is structured big data. So these are the data we're familiar with, like the National Health Interview Survey or the Census Long Form, which is now the American Community Survey. These data can be described and analyzed in conventional ways. We can we can choose an outcome variable, we can select independent variables that we think might be associated with that outcome, and we can test hypotheses with these data. So the unit of analysis has well-defined characteristics. In the NHIS, for example, we know a lot about the adult sample person's age, race, ethnicity, whether they're married or not, their sexual orientation, their gender, what their income is, their education. They're very well defined in these structured data sets. And then Medicare, which is administrative data that's been structured for analytical purposes. And then there's the SEER Medicare data, which is a very nice data set that combines the NCI cancer registry data with Medicare data, and also has a cohort without cancer so that you can do comparative analyses. Now the unstructured data, what we often think of as big data, though they're both big data, that required a new discipline for analysis. It's something called data science, and that looks for patterns. And David will be talking a lot about unstructured big data in his talk. But the unit of analysis usually doesn't have well-defined characteristics. We don't know where this sample came from, who they are, what their characteristics are, like we do with the National Health Interview Survey or the census. So it requires a different kind of analysis. And some examples of that are genomic data, Google search data, the mHealth data that you get from the mobile devices to look at different kinds of health behaviors. So what about fusing these data platforms? That sounds like a good idea because, in fact, they have different strengths and weaknesses. The structured data has a lot of demographic information and a defined population. We know who we're talking about. In fact, the National Health Interview Survey is designed to represent the entire United States population. The Behavioral Risk Factor Surveillance System is designed to represent all the states in the United States and the territories in the District of Columbia. But the disadvantage of these structured big data is their lack of granularity. both time and place. We can get information about the entire nation. We can get information on states. Sometimes we can get information on counties or metropolitan areas, but we can't get as much information as we'd like on counties or cities or neighborhoods, which oftentimes we would like in our studies. And so you all usually go and collect your own data so that you can do that. But I want to suggest that also go back and use the big data that's available to you to contextualize what you have to do, because there's a very rich array of big data available to you. Now, the unstructured data has the advantage of millions of observations, so lots of granularity, but we don't know who's in the data set. So we don't know whether we can generalize about these people or not. So fusing the data seems like it might be a good idea. So this is an example where big data, structured data, has been fused to understand environmental health disparities. In this example, researchers fused environmental data on fine particulates and nitrogen dioxide with census and mortality data to assess whether all households equally benefited from region-wide reductions in air pollution. And what they found was that racial and ethnic disparities in exposure remained, even though overall there was a reduction in air pollution. Now, these data are structured because they're all associated with a particular individual, the mortality data, or place, household, or time. And the place and time, even the environmental data, is located with a region and a time. And those are looked at over time, in fact. That's the benefit, and that's how you can see whether these things have changed. So David's going to talk about fusing structured and unstructured data, so I will leave that to him. And I believe his study is the first to combine structured and unstructured data in order to test a health disparities hypothesis. So let's look at the social determinants of health, particularly in an economic context. So it's quite well established that social determinants influence health. In fact, it's so well established that in 2010, Healthy People added an objective on the social determinants of health for the 2020 monitoring. And in fact, clinicians know about the social determinants of health and are beginning to view them as an important aspect of their practice. A 2011 survey found that 4 out of 5 physicians do not feel confident in their capacity to meet their patients' social needs, and they believe this impedes their ability to provide quality care. So if we look at the pie chart here, we'll see that clinical care is approximately 20% of what determines health. And when we add health behaviors to clinical medicine, it's about 50%. And even those are shaped by social and economic factors as well as the physical environment. So all of these things impact, which is why physicians are starting to be concerned about social determinants of health. Because what happened before the patient entered the clinic may be important to the clinical practice, and whether there are unmet needs that could prevent patients from getting treatment, care, or adhering to medication, healthy or special diets, exercise, etc. These are all things that are starting to be of concern to physicians, and they're right. Okay, so this is the punchline, the economic punchline. The upper middle class lives longer. Other groups die prematurely, and the disparity between them has gotten worse over time. So let's take a little closer at this graph. It shows male average life expectancy, and all of the top 20% groups, it's the data were divided into quintiles, and Richard Reeves, who wrote a great book called Dream Hoarders, you might want to look at it, grouped the two bottom quintiles into the bottom 40%, shown on the left. The two middle quintiles are in the middle, and the top 20%, which is doing so much better than the other groups, is on the far right. So this shows two different cohorts, and this is interesting too, because the light gray bars is the cohort born in 1920, and the dark gray bars, or the black bars, are those born in 1950. And you can see that in 1920, those in the middle and top quintiles had very similar life expectancies. But those born in 1950, there's been a much bigger gap emerging. And the differentials or disparities between the groups are bigger now than they were with the 1920 cohort. And I just want to mention quickly the benchmark study that was done on this. Thank you. The benchmark study that was done on this was by Evelyn Kitagawa and Philip Hauser, two demographers from the University of Chicago. The study was done in 1973, and they were the first to utilize big data, the structured big data from mortality and the census, to do a socioeconomic analysis of mortality in the United States by race and by income. And what they found was that the US, this is in 1973, ranked 16th among industrialized countries in life expectancy at birth. And an important reason for that was the persistence of striking differences in death rates by race and socioeconomic status. So things haven't changed too much. Now, in addition to social class, race is another big contributor. And I put this up here because I think this is the first time the New England Journal of Medicine has talked about structural racism. And it's a very nice definition that Ansel and others came up with. Historical and contemporary race inequities in outcomes result in systematic variation in opportunity according to race or ethnic background. And I'm going to focus on race in this talk. We can maybe talk more about race versus ethnicity later if you wish. So why don't all Americans live as long as the top 20%? Well, in another study, colleagues and I came up with a framework, and we think that social isolation combined with economic deprivation lead to disparities in premature mortality. And you can see here that there's some legislative history behind this, and I would refer you to Richard Reeves' book called The Color of Law, which describes it well. So I won't talk about it here, but we're at a point now in the United States where many neighborhoods and communities are resource deprived, they have community stressors, they have household stressors, and it leads to a high allostatic load. Geronimus and colleagues have found that there's a higher allostatic load among blacks than whites, and this all leads to disparities in premature mortality. So we saw what happens in an isolated and deprived situation, and that's shown on the left side of this graph. The poor tree is full of conditions and illnesses and sickness and death. And so what does it take to bring a community into a much better place in terms of the community health and, of course, health of individuals, because that's what makes up the community health. So if a neighborhood is integrated into the local social structures, political structures, economic and commercial structures, and endowed with assets in that way, a neighborhood can flourish and health outcomes will improve substantially. So let's go back to the black-white ratios, and these are ratios. So if white people are getting $1, black people are getting a certain percent. So on the far left, you see median hourly wages. These are the hourly wages that people get, and on average, blacks get about 75 cents on each dollar that a white person makes. The middle graph, or the middle bar, is the median household income, and basically this is the wages or times the hours that are worked. So, thank you. So over time, this is usually measured annually. So in that case, it's 60 cents on the dollar. Now, if you look at median family net worth, you see it's 10 cents on the dollar for blacks. So what's going on? That's wealth. All right, so there was a paradigmatic shift in wealth. I'm running out of time, so I'm not going to go through all of this because I do want to show you the graphs and I want to show you a little bit about some of the tools that NIMHD has developed. But basically, shifting from wealth, which has only been available to wealth, to looking at wealth disparities by race and income groups, has only been possible since about 1980 when the data became available. Before that, we used to look at income gaps, and we focused on labor markets. But the gaps are much bigger by wealth than by income, and it's led researchers to look more at structural reasons and also historic reasons for these gaps. And it also suggests different policies, even reparations, trying to get investment income back into communities which have historically been deprived of that in order to correct the disparity. So home ownership rates by race ethnicity, 1976 to 2016, home ownership or home equity constitutes the bulk of wealth for most Americans. And we see that a much larger percentage of whites, about 68%, whether you're looking in 1976 or 2016, own homes or are owners of homes, usually it's with the bank, than blacks and Hispanics, which is only about 40% on each end of this graph. So this is one big reason for the disparity in wealth, probably the main reason. Now, what about households with no assets? So economists divide assets into tangible and financial assets. Tangible assets included the home ownership, but also cars. A lot of people have cars even if they don't have homes. And so the percent of tangible assets is much lower than the home ownership rate. But I want to bring to your attention those with no financial assets. And you see that Black and Hispanic Americans are much less likely, or much more likely to have no financial assets than whites or Asians. So why would that be? Well, part of it is average family liquid retirement savings. This is money in the stock market or the bank, or money that you have available, somehow you've invested through your employer, your RO1k, your Roth, your something, for retirement purposes. And this can be drawn on throughout your life. It's better to keep it in there for retirement, but it's a backup. And that's exactly what wealth is. Wealth is a backup. So black people and Hispanic people just don't have as much backup. Unfortunately, data on Asians is not included in this graph, but the two things I want to mention to you is, you see here on the left side are retirement savings for whites, in the middle blacks, and on the right are Hispanics. And the first thing to notice is that whites have consistently had more retirement savings than other groups. But the second thing to notice is that white retirement savings have skyrocketed between 1989 and 2016. So federal government tax benefits are helping the top 20%. Even though they're already ahead of the game, federal government benefits are helping the top 20%. And you can see that on this graph. And then the other thing that I want you to notice is there's really only, where the green arrow is, a couple of programs that are disproportionately helping the bottom 40%, and that is child tax credit and earned income tax credit. And Joanne will be talking about her study of earned income tax credit in a few minutes. And we know that federal programs improve lives, and I'll leave it to Joanne to provide the proof, because I'm running out of time, and I just want to show you quickly, even though I have 0 minutes, I'm going to take a minute and show you HD Pulse, which is an ecosystem of minority health and health disparities resources. So check it out. It's got one portal now. It's going to have 3 in the end. This is a data portal. And the other 2 that are coming is a registry of health disparities by disease and condition. And then there'll be an intervention portal, which will be coming along, and we will be soliciting interventions for that portal. It's very similar to the NCI portal. And then AJPH in January of this year, there was an AJPH supplement, New Perspectives to Advance Minority Health and Health Disparities Research, which includes 30 research strategies and definitions for health disparities and minority health, and outcomes defined, which will help you in writing grants. And then coming soon are the common data elements for social determinants of health in the Phoenix Toolkit. So I beg your pardon for going over. I thank you very much for your attention.